Thanks for allowing me to be here and to chat with you. It's just great. So my outline's pretty straightforward. We're going to start with a smidge of humor. We're then going to go to anatomy. We're going to move from anatomy all the way to gene therapy. And then we're going to do a little bit of humor, and then I'll end. Okay. So let's see how well this works. So here we go. Boom. Okay. So, unfortunately, this is the way some of us think that we look, but as you watch as this plays, we'll see how that rolls. Hopefully it'll play. We'll play it this way, hopefully. Here we go. So here we go. Here's the young man, and he's a little bit on the tubby side. But as you watch him, yeah, okay. So that's what we think muscles should look like. Yeah, okay. So let's go to the real world. Yeah, that's most of what us look like. Okay, all right. Okay, so we're going to talk a little bit about muscle. So there are three types of muscle. There's cardiac muscle, there's smooth muscle, and then skeletal muscle. And for our one, we care about skeletal muscle. And there are 640 muscles in the body. And when we talk about muscle, so there's muscles like we think about, that's your biceps. And muscles are composed of what are called fascicles, which are smaller pieces of muscle. Oh, I see. And those contain many muscle fibers. So here are the fibers. And the fibers are filled with myofibrils, and those are the actual proteins that contract, that make muscles move. This is a cartoon that shows that in terms of muscle disease, wherever you are in a muscle fiber, whether you're in the nucleus, inside the muscle fiber, at the muscle membrane, outside the muscle fiber, or even in the connective tissue in between muscle fibers, all these little boxes are places where there are different types of muscular dystrophies and muscle diseases. And so you can tell that wherever you affect a muscle fiber, in or near it, you're going to have disease. So there are problems with the nucleus. These are the contractile proteins. Out here in what's called the sarcoplasm, which is which has enzymes and other activity. Here is dystrophin, which connects the muscle membrane to the contractile proteins. A bunch of proteins along the muscle membrane that are involved in structure and also in repair. And then there are also proteins out in the extracellular matrix and even out here in that connective tissue. So we're going to talk a little about what do you call muscle disease. And it's in a transitional phase, and so I'm going to try to move you all to the phase that I think is the right phase for muscle disease. And so you hear that term muscular dystrophy. So these are genetic, progressive, degenerative disorders of muscle. Weakness is the primary symptom. And in the past, they've been diagnosed and called by what the gene looks, or sorry, by what the muscle biopsy looks like, or what the patient looks like. So this is a muscle biopsy that is a dystrophic muscle biopsy. So this is muscle cut in cross-section, and they should all be about the same size, but a dystrophic biopsy shows very big muscle fibers, tiny muscle fibers. There's lots of connective tissue in between here. You have these which are regenerating fibers. So this is what a muscular dystrophy, a dystrophic biopsy, looks like. Nowadays, muscular dystrophies are, though, mostly classified by their gene. And so I like this term, genetic muscle disease, much better. And many of us are moving towards that because we have patients who have things that are not muscular dystrophies that have dystrophic muscle biopsies. And then we have people that have genes that are associated with muscular dystrophies that don't have a dystrophic biopsy. So I like this genetic muscle disease, and we'll eventually figure out why that is. So why do we care about muscle disease in general, genetic muscle disease? Well, there are over 200 genetic muscle diseases. The overall minimum prevalence, though, is about 1 in 1,000 people will have muscle disease. That's very similar to multiple sclerosis, and so there are big campaigns for multiple sclerosis. Of the muscle diseases that are genetic, the dystrophinopathies, that's Duchenne and Becker, are thought to be the most common. The myotonic dystrophies are another very common one, types 1 and type 2. Facioscapulohumeral muscular dystrophy, which actually is probably the most common because, like in RYR1, there are a lot of patients that have disease that don't know it for the first 20 years that they have it, and then somebody goes, oh, you should be better than you are, and they diagnose you, or their kid gets diagnosed, or their parent gets diagnosed. There are the limb-girdle dystrophies, which is what is sort of my area of interest, and then there's this group of all others. So I'm going to talk about the most common of the muscular dystrophies, and then we're going to put that into context with RYR1. So these are the calves of a 4-year-old boy. They're bigger than they should be. And mom was 39 when she had him. It was her 7th child. Mom had what was called cardiomyopathy of pregnancy. And mom was a nurse. And when mom noticed that her 2-year-old at the time, boy, had more trouble getting off the ground and he had large calves, and she said, I think I know what he has. She took him to the pediatrician. His muscle enzyme level was 24,000, and he had Duchenne muscular dystrophy. And again, in an analogy to RYR1, mom actually was not asymptomatic. Mom didn't have cardiomyopathy of pregnancy. She was a manifesting carrier. So she had disease also. It just was a different and milder disease. So here is a nice, cute picture. He's been involved in some of our gene therapy trials. He's still doing quite well. He's 11 now. All right. So here's the next most common of the muscular dystrophies. This is myotonic dystrophy, but this is a pretty normal-looking infant. Here's a young man that's playing soccer in high school. Here he is graduating from college. Here he is on his 40th birthday, and he was nice enough on his 48th birthday about 5 years ago to come in, and we took 25 pictures to get the absolute worst picture, and that was it. So these are the cardinal features that we see in myotonic dystrophy. They have my hairline. They have loss of the muscles of the temporal region. They get this sort of hatchet-faced appearance, and there's a lot of facial weakness, so they get what is called either a carp or a fish mouth, and they also have weakness around the eyes. They get drooping of the eyes. And this is the last of the 3 most common of the muscular dystrophies, and this is called fascioscapulohumeral muscular dystrophy. So fascio for face, scapulo for the shoulder blades, and then humeral, that's for the humerus muscle, the biceps and the tricep muscles. And so you can see here, obviously, there's scapular winging. They have sparing of the deltoid muscle, so they get this thing called a triple hump sign, and that's the deltoid. Here's the shoulder joint, and here's the scapula, the shoulder blade, that actually is not fixed well, and so it rises up when they try to lift their arm. They get abdominal laxity, and they have, obviously, winging of the shoulder blades, and this puts it all together. So muscle disease has different patterns. The most common pattern is this limb-girdle pattern, which is they're weak in the shoulders and in the hips. But in myotonic dystrophy, type 1, it's really a distal muscular dystrophy, so they have involvement of the arms, distally, and in the feet. There's that third pattern, fascioscapulohumeral muscular dystrophy, which involves the shoulder blades and the upper arms, but they also get foot drop, so proximal arms and distal legs. There are other disorders that have distal arms and proximal legs. There are disorders that have predominantly facial or swallowing problems. And then there are axial myopathies, which is one of the presentations that you see in RYR1. So I'm going to talk a little bit about the limb-girdle muscular dystrophies. So these are disorders with postnatal onset of progressive weakness and muscle atrophy affecting proximal muscles of the upper and lower extremities. So when you look at these 5 young adults, they all look about the same, but what's important is they have 5 completely separate diseases with different genetic underpinnings. And we now know that in the limb-girdle muscular dystrophies, there are at least 50 recessive disorders and at least 10 genes associated with dominant disorders. Just another example of a montage here. Cute little girl here. Here she is graduating nursing school. And here she is at age 50. And when you look at her, she actually has what's called limb-girdle muscular dystrophy type 1B, which is due to mutations in a gene called LMNA for lamin AC. Up here she looks like she has what we call metabolic syndrome. You see that in diabetics, they get kind of big. But when you look at her from here on down, she actually is quite thin. And I'll show you a picture. This is what her calves look like. Yeah, most of us go, that's pretty impressive, but that's actually what calves look like when there's no overlying fat. So there's no subcutaneous fat. And this is what she looks like, and you can kind of see from here on up, she is kind of large, and here on down, she's not. She's lost fat from underneath the skin, and that's a thing called a lipodystrophy. And so the reason that's relevant in her is because about 4 years ago, there was a treatment that was designed for the fat loss, so that lipodystrophy. But the nice thing about that fat loss is that it actually also improves her muscle strength. And so when she was treated, she regained a more normal fat distribution, but she also went from being proximally weak and having trouble doing stairs to now having virtually normal strength. So that's kind of exciting for us. Of the limb-girdle dystrophies, there are quite a few. There's the most common, which is calpain. This next group of 4. This one called lamin AC. And then I'm going to do the all others. And I include 4 amongst the all others that are the most common. And that includes Bethlem myopathy, Pompe disease, VCP-associated disorders, and RYR1-related myopathies. So why do I include RYR1 in the limb-girdle muscular dystrophies? So this is the Italian experience, and they took 500 patients that had limb-girdle muscular dystrophy, who they had taken a whole bunch of genetic testing and done a lot of work on their biopsies and tried to figure them out. And about 5 years ago, they said, let's do a broader look at other genetic testing. And when they looked at other genetic testing in this group of 500 undiagnosed, they found that calpain was the most common that they couldn't diagnose. But they also looked at genes that were associated with other muscle disorders. And when you looked at those, actually the most common of those was RYR1. And RYR1 amongst their undiagnosed limb-girdle muscular dystrophies was actually more common than any of the muscular dystrophies that are limb-girdle muscular dystrophies. So for me, I tend to consider RYR1 one of the limb-girdle muscular dystrophies when it presents in that fashion. This is another way of looking at genetic muscle disease. So it is really a bunch of overlapping Venn diagrams. So for me, here are our official limb-girdle muscular dystrophies. There are other disorders called Emery-Dreifuss muscular dystrophy, the distal myopathies. Here's congenital muscular dystrophy. Here are the congenital myopathies, of which RYR1 is one. But also, you can look that RYR1 really does fall into this limb-girdle muscular dystrophy. And RYR1 lives outside of that, so it can present as malignant hyperthermia, episodic rhabdomyolysis associated with exercise. So I think that RYR1 kind of has this overarching genetic muscle disease. I'm going to present however I present. Okay. Let's talk about nomenclature again. So we can diagnose and call you by what you look like: malignant hyperthermia, LGMD, exercise-induced rhabdomyolysis, congenital myopathy. We can describe you by what your histology, your muscle biopsy looks like: central core disease, multi-mini core disease, central nuclear myopathy. But we can also call you, which is what I think we should be doing, by your protein defect or by your gene that's involved, because what we're going to be fixing is the gene. So that can either be ryanodine receptor-related myopathy or RYR1-associated muscle disease. Doesn't matter what you're called, but what we're going to fix is the gene. So that's going to be a transition to what we're doing in the limb-girdle muscular dystrophies, which is genetically based therapies, gene therapy. So thus far, there is commercial gene therapy associated with Duchenne muscular dystrophy, and there is human trials of viral vector gene therapy for these muscular dystrophies. And the program is, the goal is to have those 5 limb-girdle muscular dystrophies with commercially available viral vector gene therapy by 2023. So I'm going to briefly talk about gene therapy. So this is called the adeno-associated virus. This is being used in most viral vector gene therapy. It is non-pathogenic, so it invades cells, but it does not cause disease. There are a whole bunch of different types of AAV, so adeno-associated virus. There's 6 of them that are widely used, and in muscle disease, AAV9, and then AAV-RH74 are being used commonly. So how does this work? So the answer is you have a virus. There are receptors on muscle fibers, and they uptake this virus. The virus then translocates into the nucleus. It discharges its single-stranded DNA, and then the native machinery of the muscle fiber turns that into a double-stranded DNA loop, which then becomes kind of like a mini chromosome, which we call a plasmid. So the way this works is this adeno-associated virus, this virus, has a very simple genetic makeup. It has a replicating gene, it has a cap, which is the structural protein of this virus. You can take and cut it out. You can put in your limb-girdle muscular dystrophy gene of choice, and then that is what the plasmid is, so you can make whatever that limb-girdle muscular dystrophy gene protein product is. So first, about 5 years ago in non-human primates, so in the monkey, this is what should be. You get the, I don't know how well it's projecting up there, but you see small little red outlines of these muscle fibers. And then this is the high dose down here, and you can see that we have quite effective transmission of virus and then production of protein product in the muscle fibers. Initially, this was done by direct injection into muscle, and starting last year and then this year, we've started systemic gene therapy for phase 2 in humans. 2 subjects have been dosed, and the transfection rate in tissues has been 83 to 98%, so that means 83 to 98% of the muscle fibers in the tissues that have been sampled are completely, protein product is being produced in those, and so it should be improving them. And in the animal model, we'll show you a little bit about that, how much it's showing effectiveness. And so this is where I'm going to end, is with sort of microdystrophin. So some of us consider the dystrophinopathies limb-girdle muscular dystrophies, and so we do have viral vector gene therapy that's moving into, and actually was just dosed again this spring, for this microdystrophin in humans. So I'm going to show you how this works in the dog model. So this is a golden retriever. The higher you are on this scale, the better you're doing. And so this is early. The dogs that are untreated do relatively poorly. Those that are treated do well. This is the high dose. This is then later. And most of the untreated dogs actually have lost the ability to walk and to breathe. And then the high dose are doing quite well. This is just a different way of looking at it. These are the untreated. This is, again, that same clinical scale. These are the 2 high-dose treated patients. And so I'm going to end, I think, if this will play, which I think it will, as soon as I, again, let's see if I can change this. So as you watch, you will first see, this is what a golden retriever dog looks like that has muscular dystrophy at 7 months of age. So this is a puppy that should be jumping over with no difficulty to get the treat. Again, still having trouble. So this is the untreated 7-month-old. Got the front legs over, couldn't get the back legs over. Here is a 7-month-old high-dose treated. Obviously a different manner of running. Okay, not an issue. So putting the 2 side by side, it's easy to see which is which. So this is the untreated. Now dogs are smart. You notice how he does that little Butt check? Yeah, okay. All right, so here's the treated and here's the untreated doing his best to catch up. And then we're going to end with a 7-month-old and a 9-month-old. And the key thing here is it shows that there's significant ability of their hind legs. So that 9-month-old has no trouble hopping over, and then when they go to reach, they have no trouble reaching up and jumping up on their hind legs. Okay, so we're going to end again with just a smidge of humor here. A lot of times, I've showed this for about 15 years. This is what patients say they want to look like. Yeah, I don't think so. I think this is more realistic. Okay. I'd be happy to be this guy also. So just to be able to compete with these guys, that would be great. So this is going to be our goal, is to get somewhere around here. So thank you very much for your attention.